Early on in my career, I worked at a large cancer hospital that primarily specialized just in cancer patients. And we used to get a lot of cancer patients with really widely metastatic disease, which had spread to the spine and was compromising the nerves and in many cases the ability to walk. And in metastatic cancer particularly, one of the major factors related to survival is ambulatory function, meaning the ability to walk. So those cases, a lot of times it was worth the effort to provide decompression and fixation if we were able to give the patient's ability to walk, because it would a lot of times prolong their lives. So those cases could be long. A lot of times we would approach from the front, either the thoracic cavity or the abdominal cavity. We would peel the tumor off the lungs and part of the spine. A lot of times we'd have to put fixation or cages there to help provide support for the spine. And then we'd flip the patients onto their belly and do more decompression, more fixation from the back. So those could go on for 12 to 15 hours. A lot of times they were sick patients. A lot of times we had to use what's called a double lumen endotracheal tube, which means we'd have to take part of the lung down in order to get to the area that's affected. Of course, you'd always get breaks when the thoracic surgeons are doing part of the exposure. You would have some time off, but a lot of times you would stay in the room there. You'd want to maintain a line of communication, because a lot of times these are sick patients, and you want to be sure you have your finger on the pulse of what's going on. So when you're there for your part of the surgery, you can anticipate any problems. So those were long cases. They tended to be psychologically and physically very draining cases, but extremely rewarding, especially when a patient who wasn't walking regained the ability to walk.